मेरा अर्धाच दिसतोय.
थोडासा खाली करा,
खाली
लॅपटॉप
कर.
थोडासा टिल्ट करा. हा, करेक्ट. फेस
Excuse
पूर्ण
me.
नाही दिसत आहे.
Excuse me, doctor. Yeah, we
Yeah,
are
let's go
live.
live. Yeah,
We are live now. You can start.
yeah.
Good evening, everyone. I, Dr. Preeti Kamdar, Secretary of MOS, welcome you to one more episode of our One Printout, One Session series. And today's is a very important topic. It's confusing, it's volatile, but it's one of the only functional tests we have, and that is perimetry. And perimetry has stood the test of time, and also it has succeeded in confusing people for over so many years. So we have a wonderful orator, Dr. Manisha, who's a very experienced glaucoma surgeon from Mumbai, and we have a team of wonderful panelists to answer your questions. We've got a lot of questions on Google Form. Before we go ahead, I hand over the mic to Dr. Anaga Herur, President of Maharashtra Ophthalmic Society, for her views on this subject.
Yeah,
Hi,
thank you,
Anaga,
Dr.
please.
Preeti, and welcome one and all to this one more episode of one uh, procedure per month. So this basically we had conceptualized so that we can focus on one procedure, whichever we are using. So we have already covered biometry and corneal topography and OCT, RNFL. So there are so many things that uh, these procedures actually demand the kind of attention, the focus, which really can be covered in one complete webinar. So that is why we decided to have specialized webinars on this. And I'm really glad to share that a lot of these webinars have been very popular with all, not only MOS members, but all over India too. So we are very happy and thankful to Dr. Manish for consenting to share his inputs, and for all our expert panelists also. Dr. Preeti herself is a glaucoma surgeon, so we will really have an excellent discussion. So over to you, Dr. Preeti, and to the panelists.
So before we start, let me introduce my co-moderator. She's Dr. Cheta Vishwe. She's a glaucoma specialist from Aurangabad, Sambhajinagar. And then we have Dr. Maya Modawala, who's again a very promising glaucoma surgeon from Mumbai. And of course, Dr. Rupali Nerlikar, an experienced glaucoma surgeon from Pune. And we are going to be joined by Dr. Rita Dhamankar, who's the senior most glaucoma surgeon from Mumbai, and I think in Maharashtra also. So without any further ado, I pass over the baton to Dr. Manish Shah for his talk on perimetry decoded. Dr. Manish, please.
Thank you very much, Dr. Preeti and Dr. Anaga, for this opportunity. And it is really a topic which is quite large, and I have tried to cover it in as short as possible, but covering most of the things. So I'll be sharing now. Can you see my slides?
Yes, yes.
Sorry, this is not the first. Okay. So basically, we are all doing perimetry, and it is really the applications have increased quite a lot, and it is absolutely essential in a glaucoma practice, but even in a general ophthalmic practice. So, what is actually perimetry or visual field testing? So what we are doing is that we are actually evaluating the sensitivity of the points, various points on the retina, and that is called static perimetry. Just as visual acuity is a measure of the sensitivity, but only of the fovea. But we cannot measure visual acuity at different locations. So we are using to measure sensitivity, and by the method called static perimetry. And in glaucoma, it is extremely important because the disease in the initial phases just presents with some areas of vision loss which do not affect the patient at all, and patient is totally unaware. Only by testing can we catch these cases at this stage. Later on, the defects enlarge, and that's when the symptoms start, but that is already late, and these defects cannot be reversed. So to treat them and prevent the morbidity of glaucoma, we have to detect them earlier. Hence, only if we detect them early can we prevent it from going to the stage where it affects visual function. So that is why it is very important. So what is the method we are using for testing? Is called automatic static perimetry. What is the importance of this? The stimuli we use are standardized. So in olden days, people used to do manual perimetry and we used to use various targets. Now that is all obsolete or we rarely used, and now we are using standardized stimulus. And because it is standardized, you can use statistical tools for interpretation, and evaluation of change or progression also can be done very nicely, as we are going to talk in this. We are going to come to that little later. The principle is that the retina sees brighter stimuli more easily than the dimmer stimuli. And sensitivity is the ability to see the dimmest stimulus. So if your retina is very sensitive, it will be able to see a very dim stimulus. So sensitivity is also, there is a fluctuation, natural fluctuation in sensitivity. It is not always fixed at one point. The same stimulus can be seen sometimes and not seen sometimes. So the intensity of stimulus, which is seen 50% of the times it is presented at a retinal location, is defined as the sensitivity. Higher the signal, lower the sensitivity, lower or dimmer the signal which is seen, is the higher the sensitivity. So you can understand it is reverse. Now these are the physics measures of luminosity, which I am going to cross because I think it will be too much. So when you want to go on reducing the stimulus intensity, we are using filters. The machine uses filters in front of the light source, and the strength of the filter used is expressed in log units or decibels. So the visual field report shows us thresholds in decibels. So what are these decibels? The decibel is the filter strength which is used to make the stimulus dimmer. So as I said earlier, the stronger the filter or denser the filter, dimmer the light, and if that is seen by that point, that means that it is a very sensitive point. So higher dB value, higher sensitivity. And lower dB value means the filter strength is very low and the stimulus is very bright, and that means it is lower sensitivity. Now, when we do the tests, you have got two types of tests. One is called a threshold test, where we are aiming to determine the threshold of sensitivity at all the locations. The supra-threshold test is when we are just testing, it's like a screening test just to make sure that all the points are, none of the points are depressed below what we expect, and all the points are sensitive to as expressed by the non or age matched normal. So that is a screening test. Now in the Humphrey, which I'm going to talk about, there are various test strategies, and there is a lot of confusion on what this exactly means. The oldest and where we started is the full threshold test, where all the points in the field testing area are tested in a uniform manner in steps of 4-2-2 with 2 passes. What it means is that first a bright stimulus is presented, and then the stimulus is made dimmer by 2 decibels each time till it crosses the threshold so that it is not seen. Then it is increased by 2 points so that it is seen, and then it is reduced by 1 point. So you get the exact sensitivity of that point. Besides that, in the full threshold test, 10 points are tested 2 times to get what is known as short-term fluctuation, so intra-test variability. Because it is so rigorous, the time it takes is very long, sometimes 12 to 15 minutes. Then the new technology which came in was the CETA standard, which was a smart test strategy aimed at reducing the testing time. So the test starting point in full threshold, all the tests start at the same level. In CETA standard, the test starts based on an algorithm where the machine already knows what to expect at a certain particular point in the eye. Second is the test is done so that it is reduced in steps of 4, and from 4, then 2, and then 1. So the testing steps are reduced and no double tests are done. Because of that, the test time is reduced to 6 to 8 minutes. Then we have another program called CETA Fast, which is very rapid because the large steps are tested. So it is more like a supra-threshold testing. You do not land up with a very accurate measure of the sensitivity, but a gross measure, and time is really saved. But in glaucoma, CETA Fast is only to be used in patients who are really uncooperative. Now the newest technology which has come is called CETA Faster. That is a upgraded version of CETA standard, and the testing time is reduced to 2 to 4 minutes, very short time. And many studies have been done to show that there is not much significant loss of data between CETA standard and CETA Faster. Now, the second part of the test is what is the area tested. You have 30-2, 10-2, 24-2. So 30 means 30-degree field. 10 means central 10-degree field. And 24-2 is a mixture where in all the three regions it is 24 degrees, but in the nasal it is extended up to 30 degrees. This is to reduce the number of test points and test areas so that test time also becomes less, but not compromising that most of 90% of the glaucoma defects are going to be in these areas. So this is the 24-2, and we use it very commonly for glaucoma patients. And then you have the -2 part. What does -2 mean? -2 is the way the points are located on the screen, and the stimulus locations in the -2 version are not exactly on the horizontal and vertical meridian. They are just equidistantly just off the meridian. This is important because in general defects in glaucoma respect the horizontal meridian, and neurology defects respect the vertical meridian. But if you test exactly on the meridian, the next point will be 6 radians away, which would be too large a gap. Therefore, we have the -2, and most commonly used is the -2 program. A standard machine you buy will not have the -1 option until you ask for it and probably have to pay extra for it. Now, coming to the next thing is what is the typical layout of the report. Now, this is the report which has been known as the Humphrey layout report, and then it has become so popular that almost everyone, all the machines have now copied this. What we have over here is the basic data of the patient on the top. Then you have the test data, which is there, which tells you what is the size of the stimulus. Normally in glaucoma, in normal testing, we use a size 3 white stimulus, and the background illumination is fixed by the machine. Besides that, you put in the pupil diameter, you have to put in visual acuity, you have to put in. If the technician doesn't put in, it will come blank, as it is in this case. And in the next is the reliability parameters telling you exactly what is going on in the machine. And most important, we will be talking about fixation losses, false positives, false negatives, and fovea off. Now, many people like to keep the fovea on because it gives you a generalized measure of sensitivity. And I personally don't like to keep fovea off. It saves a little bit of time. So I generally keep it off. Now, that is personal choice, who likes to do what. So this is a full threshold test which I was mentioning. And here you can see all those. These are the data which has been put over here is the raw data from the test. And these are the decibel values of sensitivity of each point. And where you see a bracketed second value is the points which have been tested twice. Then you have the total deviation here, which is the age-corrected deviation from this patient from an age-matched normal. And if there is anything significant, it is plotted on this graph below with a probability index, which is over here, less than 5% up to less than 0.05%. So that is the significance of the defect. The second is the pattern deviation, where overall defects in the sensitivity are adjusted. So if there is overall drop in sensitivity because of cataract, or overall drop in sensitivity because of the patient having some corneal problem, or if the patient is having a little smaller pupil, all those factors will affect overall sensitivity, and they are all minused off, so that this pattern deviation is more designed to give us localized effects rather than generalized effects, which is what you see in glaucoma, because you will see localized effects. Then you have the other last box over here, which says GHT. GHT is glaucoma hemifield test, and I will be talking about this. Then you have global indices, which are mentioned here. MD is mean deviation. PSD is pattern standard deviation. SF I mentioned is short-term fluctuation, which you will only get if you are doing a full threshold test. And CPSD is corrected pattern standard deviation, where PSD is corrected for short-term fluctuations. So SF and CPSD will not be there when you do CETA tests. And nowadays, we rarely do full threshold tests. We are nowadays doing CETA or CETA faster. So this is the printout of the CETA faster test. And as you can see over here, most important, I would like to point out the test duration of this test is only 2.25 minutes, which is really quick. And the amount of data it has given us, and this is the 24-C program, 24-C, because central points are increased. What happens in the standard 24-2 program here, as you can see, there are very few points which are in the center. And as we know, in glaucoma, the quality of the visual field or vision is dependent very heavily on whether the defects are affecting the central region. And these are the central points. So there is a whole cluster of central points extra over and above the 24-2 test in the 24-2C program. And when you do CETA or CETA faster, there is one more index which comes in instead of means additional to mean deviation is VFI. And we are going to talk about this also. This is known as visual field index. So all these things I am going to talk about now. The reliability indices, false positives, false negatives, and fixation losses. False positives are when there is no stimulus presented, but the machine makes a little sound with each stimulus, and only sound is made, and the patient gets fooled. He hears the sound and thinks that there must be a stimulus, presses the button. So that is a false positive. False negative is when the machine presents specific signals to specific locations which are very high. So very bright stimulus, you cannot miss all. It's already a tested point and the patient has already given the threshold. But this machine gives an extra stimulus over there, which is very bright. So only if the patient is not attentive is he going to miss it. And if he misses it, that gets recorded as a false negative. Fixation losses are measured in the Humphrey machine by the blind spot method, where from time to time the machine gives a stimulus at the blind spot location. And if the patient says, I can see it and presses the button, that means that the blind spot has shifted. That means the patient's fixation has been shifting. So these are the measures. Now, what is significant in false positives, false negative, and fixation losses? We don't need to remember the percentages because the machine points out them as a double cross. So I would like to not confuse people. The global indices mean deviation is what is mean deviation, what is pattern deviation, and what is short-term fluctuation. I'll just explain. Mean deviation is when all the points are tested, it is a mathematical calculation of how much the mean sensitivity of that field is how much and how much does it vary from an age-corrected normal. Pattern standard deviation, as I had explained earlier, corrects for localized effects. So higher the pattern standard deviation, you will get more localized effects. Generalized effects, pattern standard deviation becomes low. Short-term fluctuation is intra-test variability, which is only there in full threshold tests, rarely seen these days. And CPSD is also derived from the pattern standard deviation, which correction for short-term fluctuation. So that also is rarely seen today. So I think we can skip it. Now coming to the glaucoma hemifield test. So this is a very smartly designed test to compare the visual field in the superior and inferior part of the visual field. So what the machine has done is that there are 5 zones, and these zones are pointed out here on this chart. So this is zone 1, 2, 3, 4, and 5. The thresholds at each of these zones is compared with mirror images in the inferior field. So like this has these 3 points, it will be compared with these 3 points. And then the statistical answer is given. So if any two of those zones show a difference which is large enough to be found in less than 1% of normal population, it is pointed out as abnormal. Borderline is when the difference is found to occur in less than 3% of normal. So any two zones, not one zone, any two zones. Then there is something called a generalized reduction in sensitivity when there is no significant difference between any of the two paired zones, but the best part of the visual field is depressed to a level found only in less than 0.5% of normal patients. And abnormal high sensitivity is when the best part of the visual field shows sensitivity higher than that found in 99.5% of normal people. So this also is flagged on the report over there in the GHT or glaucoma hemifield test report. So next important point in the visual field, which I would like to point out, and this is very important, is that glaucoma severity. When we talk about the target pressure and we talk about how we are going to treat the patient, we classify into stage 1, stage 2, stage 3, stage 4, stage 5, mild, moderate, severe, advanced. And how do you classify? It is based on mean deviation, pattern deviation, whether there is any involvement in the central 5 degrees of the field, and what the hemifield test shows us. So you are going to classify the stage of the disease not on OCT or not what you see on the optic disc clinically, but only on perimetry. So this is an important message I would like to give, and the details are all here, and probably you can get it by copying that chart. Now, these are the typical defects that you get in glaucoma many times. So these are very typical defects. So this is a report, as I had explained, this is the older test technique, which I was using earlier, which is the full threshold test. And it is showing you over here all the reliability indices. And as I said, if any of the reliability indices is marked with a double cross, that means there is a problem with the reliability over here. Then you see the gross sensitivity pictures, and you can see the second tests. So sometimes I like to see this because you can see the difference in the second test. Sometimes it can be quite a lot. Like this is, you can see when the same point is tested twice, sometimes there is a lot of fluctuation. Then you get total deviation, which is the deviation from an age-matched normal. And the second part is the pattern deviation, which is correcting for overall changes in sensitivity, which is affecting all the points. So you can see some of the points which are marked out as abnormal over here are not marked out over here, and more concentration is given to this nasal defect. So very commonly in glaucoma, you get nasal defects, whether it can be just one side or this is a typical nasal step formation. And you can see over here, this is the mean deviation and pattern deviation. Now, this is a CETA standard test, and therefore there is no short-term fluctuation and there is no CPSD. And you can see all the reliability indices here are marked out, but none are marked with a double cross. That means this is, you can assume to be a reliably done visual field. Now looking again at the raw data, as I said, in the CETA test, there is no second testing, so no figures are there in brackets. The total deviation plot is definitely showing a big cluster, which is there in the inferior nasal part, and a small part is there in the superior field. But when you correct this pattern with the pattern deviation for overall changes in sensitivity, then you see that only the one which is pointed out in the lower inferior nasal portion is pointed out. The other ones are all cancelled out. So probably this patient has some amount of cataract and or some media problem, because of which more points are seen in the total deviation, and pattern deviation is showing fewer points. So this is another one where you can see that again it is reliably done visual field, and the raw data is showing quite a few points, but they are all double tested, means this is a full threshold test. The total deviation again shows quite a few points, but the pattern deviation shows only points in the inferior arcuate. So there is some overall sensitivity problem here, but there is definitely a inferior arcuate scotoma. Now what is the use of this grayscale which we see over here? This grayscale is not absolutely useless. It is very useful to identify certain errors or certain artifacts, which I am going to come to shortly. So now the next important point is when you see a visual field report, it is very important to correlate with the structure. So structure function correlation or interpretation of visual field is not complete until the structure function correlation is done. So visual field findings must be matched with optic disc and fundus findings, which include optic disc, nerve fiber layer, other fundus findings, and of course also if you are done an OCT, then OCT findings also. How do you correlate? So this is another very important slide which tells you in a normal disc, not in a tilted disc or not in a disc which is a variable or varied in shape, but a proper nice round oval shaped disc. This is how the locations are. And so when you have the temporal part, that corresponds to the central papillomacular region. And usually these points are the last to get affected in glaucoma, as compared to the inferotemporal and the superotemporal, what is marked in yellow, which corresponds to these blue areas here and here. These get affected very commonly early in the disease. Then you have the inferonasal, which is going to go right up, and the nasal portion goes in this region. So this is a typical 24-2 test, and these are the corresponding areas on the optic disc. So if you see a notch over here and a nerve fiber layer defect here, that means the visual field defect should be in this region. That is what I mean by optic disc structure function correlation. Now, common visual field errors is high false positives, artifacts, patient having poor concentration and giving high false negatives, and the common lid and lens rim artifacts. As I said, the gray scale printout here is very useful for identifying these kind of artifacts and errors. So this is a patient who has, you can see over here, high false positive errors are marked in double cross. So I have blown it up over here so that you can see it very carefully. Typically in this test, the testing time also increases because the machine gets totally confused in this test. And what happens is that certain areas in the visual field have abnormally high sensitivities like 40 and 50 decibels, which doesn't happen in a normal patient. This is because the patient has gone on pressing the button. So what happens is that you get these areas which we call white scotomas. When you see white patches like this, it is diagnostic of high false positives and it masks the real defect. So this test is actually quite useless for us because the real defects are completely masked. And what happens in the pattern deviation is again a statistical error. The abnormally high sensitive areas have been marked out as normal and the normal areas have been marked out as abnormal. This is because of the statistical program which is there. The other two common artifacts which keep appearing in testing day to day is one is the upper lid because patient is sleepy or patient has got a ptosis. And the other is the lens rim. We are using correcting lenses while doing the test. And if the lens is too far or not centered, the edge of the lens projects into the central 30 degrees, which we are testing, and it shows up as a defect on the visual field. The characteristic is that it will be a sharply demarcated absolute defect. As you can see over here, it is an absolute defect. As you can see over here, there is no variation. All are 0, 0, 0, 0, 0, 0. So it is usually a sharply demarcated defect. And as you can see here, the grayscale is a giveaway. It shows you that the blind spot, which should have been somewhere here, has gone right at the edge. So this is a patient whose eye has moved or turned so that the edge of the lens rim has come into the testing area. And this is the typical defect you get when the patient is sleepy or patient has got ptosis. The upper field gets affected. And if you do, this is where sometimes we can do in the full threshold, we come to see that, in initial part, you get proper thresholds and then the threshold drops because when you do the second test, this happens because the lid has dropped afterwards. The same patient, you tape the lid or make them awake and this defect usually disappears. This is anticipation. You have to see this because the reliability indices are all within acceptable levels. So this is another example where you have to be a little watchful. So this is a patient who had a visual field test, and if you can see, reliability index is all 0, 0, 0. Beautiful, very, very reliably done test. And there is a defect which is seen. 2 points are seen and they are marked out as very high p values. So what is happening? And then when you do the structure function, I don't have the picture over here, but the structure function did not explain a defect which should be located here. And this is the typical thing which has happened, because during the test, the patient's head has moved backwards and the blind spot has moved upwards. So this is an extension of the blind spot which has got tested. We did the test again by keeping the patient's head very well aligned with the forehead rest, and you can see that defect disappears. This is the typical defect which we call the clover leaf defect. What is a clover leaf? Clover leaf is like a champa flower leaf. It has got four petals. So these are the 4 petals you see. The clover leaf defect which you see is because of high false negative errors, as you can see here. What has happened is, when the testing starts, 4 cardinal points, the first testing is done in 1 point in this sector, 1 point in this sector, 1 point in this sector, 1 point in that sector. And that is the time patient is awake. So he has pressed the button properly and those points have come out as normal. After that, patient has started falling asleep or is drowsy and is not been pressing the button consistently. Because of that, the other areas come out as black and you get a typical cover leaf pattern. High false negatives are marked here, and GST also shows low patient reliability, and you can make out that this is because of patient falling asleep or being inattentive. Now, the second part of the talk I would like to bring out is on the progression of perimetry. So once you have done the test, you are going to do the same test again to know, is the glaucoma progressing? So how do we know whether it is progressing? The technique is to measure the function of the ganglion cells. When we get a technique to measure ganglion cells, we'll stop doing perimetry. So I'm looking forward to that day. I don't know when it is coming, but that is not possible today. So we have got surrogate measures. So visual field is the time tested method, and we have imaging technologies which are now coming up and we are using it parallel. Vision and other visual function parameters are also there. So when you use the visual field or the perimetry for progression, there are 2 main ways that you are going to look for progression, and it is important to look at both. It's not either or. So this is event analysis, where you have one field and you compare the new field to that field and look for change. So put both side by side, and that is the event analysis. Trend
Manish, we are not
analysis.
able to see that. Have you put on those slides?
Are there? Oh, sorry.
No, they're not being seen.
They are not seen? Wait.
No. It's your old thing which is seen.
Okay. I will just reshare.
Yeah.
Now can you see?
It's just starting. Yes, now we can. Yes, thanks.
Yeah. So you have event analysis and you have trend analysis. Trend analysis is that each follow-up test results are plotted on a graph. So you get a graph which shows you where it is going. Just like you have stock exchange, you want all your stock prices and to go up like this. So like that, in the visual field, we want them to remain stable. If they start going down, that is bad for us. And what we get is the rate of progression. So there is something known as acceptable rate of progression. So, we are always telling patients that when we treat you, we can't rectify what is defect, but we can at least treat you so that it will remain where it is, which is the biggest lie. We are not able to even stop the progression. We are only bring the progression down to an acceptable level. So when you become as many glaucoma patients over 20, as I have seen over 30 years, then you realize that this is not a truth what you are telling the patient. So you have to bring the progression rate to an acceptable level. And I'll show you some examples how that happens and how that doesn't happen also sometimes. Now why it is not changing? So how to decide progression? Now there are criteria which have been put for generalized depression, mean reduction if you see a p-value reducing by point or up to 1% or reduction of 3 decibels at all points, which is not explained by media opacity. I will just go over these criteria just for everyone's information. What I want to tell is that none of the glaucoma specialists are sitting with the printout and using this in each case. We are relying on the software and looking at the charts ourselves. So these are only for research that these are there. But since I am giving a talk, I have to bring them up and I am bringing them up. So if you have a previous defect which is deepening, you need a cluster of 3 non-edge points with 10% reduction, 10 decibel reduction of each, or a cluster of 3 non-edge points or 3 points in the same scotoma which decline for more than 5 decibels if the p-value is less than 5 at baseline. So this is complicated, but that's what it is. For expansion of pre-existing where the defect has increased at least 2 previously normal points within the central 15 degrees or 3 points outside the central 15 degrees which decline by more than 10 decibels or get depressed by more than p-value more than 5. But the most important is over here. It has all these changes are relevant when they are seen in 2 consecutive and confirmed in the 3. Now, the point which I want to make is that perimetry is a subjective test and test-retest variability does exist. We often see even patients who have been doing perimetry for years together, suddenly one of the days they come up with a perimetry which is showing many defects. So you don't jump onto progression idea by just doing a perimetry once. You have to repeat and repeat 3 times before you can really rely on it. So 3 non-edge points in a cluster of more than 5 decibel reduction or a single point more than 10 decibel reduction in 2 consecutive fields will give you a suspicion of progression. Now, as I said, who is going to sit and apply these criteria in each and every chart? Instead, we depend on software which is available in the machine. The old software which is available was known as glaucoma change analysis, which was purely statistical. But it took 2 initial fields, reliably done fields as baseline and compared each of the next coming repeated fields with these 2 as baseline. And it only gave a solid triangle which indicated worsening from baseline and a clear triangle which gave improvement from baseline. So these are the examples. Now, when you have a field like this this is the baseline number is on the left side and the right is the follow-up. You don't need any software to tell you that this has progressed significantly. So sometimes just looking at the field is enough. Now, this is another example where I definitely like to look at the whole field, and this is a patient who has been following for a long time. And what I want to show is that only that if you see the points, like this is the pattern deviation, you can see here abnormal points, they become normal in one test, they become abnormal again, then suddenly they become normal again. This is exactly what I want to point out, that in perimetry, and these are all reliably done fields. When you have a repeat test, sometimes the reliability also goes down and you get these defects, some improve and sometimes they worsen. Very difficult to tell. Now, this is the change analysis software. As I said, it is showing all these solid triangles, which are points which have worsened. Now, we are not using this software anymore because now we have the new software, which is the GPA or glaucoma progression analysis. So, there are many questions which had come in the questions about the perimeters, the Indian Appasamy perimeter and all. The importance of the Zeiss and the octopus perimeter, especially the Zeiss, which I know more about, is that this GPA software, it has used theta and pattern deviation plots to identify glaucoma-specific progression. They have enrolled glaucoma patients. So these are already patients who have glaucoma. And tests have been done, and they have taken out the likelihood from these patients is that stable glaucoma patients versus progressing glaucoma patients, at each of the points in the visual field, they have brought out the significance by statistical studies, and it employs strict progression criteria from the EMGT study base, and it gives you a slope to identify high-risk patients. You cannot, get all this in the other machines because they have not done these kind of studies for progression. So when you are treating glaucoma patients and you are going to look for progression, it is very important that you have the machine which is having a backup of all this research data and software. So what happens is that you require a minimum of 2 baseline field tests, and then you require 1 follow-up. Each follow-up is then compared to the average thresholds of the baseline, and additional follow-ups are compared both to the baseline and the last 2 most recent follow-ups. Now, when you have a patient who is with you for a long time and you have done many tests, over the years, I'll show you patients whom I have had for 20 years. What is the point of comparing today's field with his 20-year back field? So they compare with the 2 most recent and gives you this result. That is, when you have a clear triangle, means the first time there is progression with a 95% p-value significance level. When the same point is seen to progress to show that same kind of change in the second time, it is pointed out as a half shaded. And when in the third test, the same point shows the change, then it is pointed out as a solid triangle. And the GPA will tell you when the second test shows, it will say possible progression. When it is confirmed on the third, it is going to say likely progression. It is a very strict criteria. So these are all the baseline, the multiple tests that you have done over a long period. Now, this is where the 2 are taken as baseline and the follow-ups are all compared to these 2. And it shows you the result here. As you can see, in the first, you have got some triangles. The second time, you can see triangles which have become solid. And here you get the result in the third, likely progression. In the second one, it just says possible progression. So here it has identified. Now, if you just look at these fields without looking at the software, even any person will say that there is progression in the inferior arcuate region. So this is how the GPA printout is going to be able to show you. This is just to show you a little better. This is where you look for the reliability, and this is where it is going to show you low test reliability if that has been applied. And finally, a very simple language, likely progression means 2 times in 2 consecutive fields, some points have turned out to be progressing. As you can see over here, there are half shaded triangles. And in the final one, you will get progression. It's the same way. This is a different kind of printout. The same data is printed over here with a small additional single field analysis on the side. So here is this just blown up the same picture, and you can see here the shaded triangles, solid triangles, and this is the cluster which is showing up in all the tests. As you can see, some of these test points are not seen in the final test. So there is variation, as you can see. But these 5 points over here are consistently showing, and that is why it has given you a message, likely progression. The new GPA is that it is new default single page GPA printout, and the new metric is the VFI. Now, what is VFI? VFI is known as the visual field index, and visual field index is a new index which has been brought out by Humphrey. It measures the age-adjusted overall visual function and gives more importance to central points. In mean deviation, it is just a statistic of all the points. While in VFI, it is given as a percentage, and percentage matched with age-matched normals with a higher weightage for central points. So you can plot a graph of the VFI. I will show you that graph also. So this is just another example of a patient which I have been seeing, and you can see the overall picture. If you just sit with this, you can make out that in the test here, some points are, and you can see more points are appearing here, and definitely the same points are adding up here. And so there is definite evidence of progression. Now you don't require that much of statistical, sorry, what has happened? You don't need the statistical, but still when we use the statistical, now this is what I am saying is the VFI plot. So these are the various VFI plotted as percentage against time. And you can see in the last 1, 2, 3, it has been dropping. And the machine extrapolates this further to show you that if you don't do anything, where the patient is going. And this is a graph which shows you in 5 years how much he is likely to deteriorate. So this gives you an idea about how severe, and it gives you rate of progression that is marked out over here is minus 0.4 or 0.2% per year. So which is at confidence interval of 95%. So this is what it gives you, the rate of progression. And that's what I was trying to tell you earlier, that when you see progression data, the rate of progression is important. This on this field, if this patient lives longer and we don't do much, is he likely to have a visual field defect which will affect his quality of life? Just looking at this graph, no. But when you look at the location of the points which are worsening, the closer to fixation, more likely it is going to affect his quality of life. So in spite of the fact that this VFI graph is not showing that significant progression, I would count this as important and probably like to take some action on this patient.
Manish, it's going to take some more time.
Yeah, and I'll just show you some examples, that's all.
All right, yeah.
So this is another patient which I want to show, is that this is a patient with a long period of time from 2013 to 2019. So this is, I have been following up and seeing. Now what has happened is that initially there was definite progression is seen. Whenever the progression is seen, what we do is basically reduce the interval between test and the retest. So do more tests. So when we saw this progression occurring, we have tested the patient at every 3 or 4 months and seen that then it was stable. Then it remained stable for some time, and then again we saw some progression. When we see progression, again you can see this is the interval between the test times is reduced to a few months. And again it becomes stable. So important point over here is the retest a chart or retest order that you give should be on what you see on the chart. If you see progression, you have to do the test more often so that you can confirm the progression. If you don't do the test more often, you will lose a lot of time. And this is one more example. This is probably the last. And this is a 10-2 field done. And you can see over here that the superior part is involved, but inferior also there is a little involvement. And this is also from 2024, 25, 26. And 2 tests are done in 26 at a very short interval. And you can see that this is just for me to confirm, because I was a bit appalled that there is a big cluster which has appeared new over here, which is showing significant progression. And I was worried because obviously 10-2, this is a patient who already has advanced glaucoma. And what I would like to point out on this is that this is what the patient had. He had a little bit of traction on his macula, and this is the test which had been done earlier. I think the date is not, I think it's not seen, but this is the one which was done in 26. This is in 24, and you can see that his traction had increased, especially in the inferior portion or in that region where we see more progression. So even in progression, you have to keep looking at the fundus and see, correlate with other fundus findings before you jump onto the diagnosis of progression. I think I have already exceeded time, so I'm stopping it right here. I had some more examples, but I think it's too much.
No, it is a very in-depth explanation of perimetry, and it's a very difficult topic, very vast topic. And 1 hour is too short, 40 minutes is too short a time. So thank you for covering progression also. There were quite a bit of questions which were asked on neuro-ophthalm. And that's the reason why I have put, you had already made your talk. So that's why I have put a few questions on neuro-ophthalm. One moment. Yeah. Not questions, but are you able to see my slide?
It's half a slide, ma'am.
Half a slide, okay. Yeah,
At least for me.
Yeah, I'll shift it.
Yeah.
Now you can see it.
Now it is okay.
continue to share. Yes, continue to share. All right. You're able to see this?
Yes, yes.
Yeah. So now Manish had already made his talk, and there were a lot of questions on neuro-ophthalmic perimetry also. So I put a few slides together. Now this was the first a person who had 6/4 vision, and but he said the last two, the temporal ones are not clear. He said the outer ones. I'm saying temporal, and with 6/4 visions. But when he was very specific, that's when I put the person on the perimetry, and this is what I found. This is a patient with 6/4 vision. So you have to realize that the right eye is showing a proper hemianopia, but the left eye, on the pattern deviation, it shows you hemianopia. But if you try to look at the grayscale, it does not give you the full visual impression. But that's because it's early. So early, this is all three spectrum I have kept. So this is an early scotoma where you will find one field. Yeah. You said something. Anyway, so one field will show a hemianopic pattern and the other will look hemianopish, may not be completely, but that is because it's early. Now we come to this is a person who had a metastasis in the visual pathway. So here you are not seeing a hemianopia. You are seeing, because it's a very focal defect posterior to the optic chiasma, but you will find that even these lesions, they will respect the vertical meridian. So here they are not going to see a defect which is typically what is seen in textbooks like a quadrantonopia or a hemianopia or a pie in the sky or pie on the floor. It's not. It's somewhere in the visual pathway posterior to the chiasma, but it's respecting the vertical meridian. And second is, it is homonymous. So this is again one more characteristic of a very focal lesion in the visual pathway. Could be mostly due to metastasis, because these are small lesions. Usually those which are because of any hemorrhage or ischemia, they are much larger. But metastatic lesions can present like this. When I did a 10-2, again, you find out it is respecting the vertical meridian and has a homonymous pattern, a symmetrical across the two eyes. And now this is one person who has and very advanced. He was operated for a pituitary adenoma, very advanced. So if you see here, it is not respecting the vertical midline, and particularly in the left eye, it is breaking across. So in very advanced cases, you will find that again, it is hemianopish. It is not a perfect henopia, but it is trying to be hemianopic, but it will break across the vertical meridian because it's advanced. So you have seen focal, you have seen a proper hemianopia early and late. But whenever you see these lesions, you will find, when you compare the two eyes, you will find the temporal field affected, which is not usually affected in glaucoma. And plus, you will find that they are congruous in post-chiasmatic lesions. In chiasmatic lesions, they'll be bitemporal, and depending upon how severely it is affected, you will find that they may break across the vertical meridian. So this is just what I wanted to bring across in neuro-ophthalmic perimetries in a very short time. So I'll stop sharing my screen, and we have had a lot of questions. So let's take those. So
Preeti, can I make one comment about neurology while we are still on it?
Yeah, sure.
Right.
Sure.
So a defect which is very exquisitely congruous points towards a vascular pathology, while a non-congruosity more in favor of a compressive pathology. To suspect a neurology defect, one is vision tends to be affected. Patient is at least aware that he has a problem. So it's like a positive scotoma as compared to a negative scotoma, which happens more with glaucoma. And color vision might or might not be. The red-green which we test with the Ishihara is likely to be abnormal in some of these, not always. If it's like a visual tract onwards, it won't be, but the more anterior lesions can have color vision defects also. So these are all clues which will help us if you're confused. Is this like especially in the later ones when you showed that there's a breaking through beyond the vertical.
Yeah.
Then if you're confusing, it looks like a glaucomatous defect, then these are things which will help you. And in these patients, if you also, to correlate, if you do a ganglion cell test on the OCT, that can help us pick up that vertical pattern a little better.
Very true, Rupali. That was nice points which were brought out. Can you just switch on your video? Dr. Cheta, also, if you can switch on your video. So there were questions were, I'm taking the first question. When should a CETA fast be done? So, Dr. Rita,
Oh my
when
God.
would, yeah, you're the first candidate, yes. So when should CETA fast be done? Because
So,
we have,
yeah. I believe that it is a very good idea to do a simple 24-2C. I use it as a screening test more often because ever since it has been available, I did a study on it myself, and I found that it is very easy because it is done in a shorter time. So the patient is less likely to make mistakes, and it also covers those 10 extra points around the center. So visually disabling defects are picked up very quickly by this. And if you keep repeating it, you can also get, you can see progression, you can follow the patient up. The patient is more likely to do the perimetry. If the patient has to do a long test, there are more chances that he will, do many mistakes, so the field becomes unreliable. And therefore, I prefer as personal choice. This is only my personal choice. It's not like a dictate.
okay.
So I prefer to do the 24-C more often than I prefer to do a simple CETA or a 24-, CETA standard or a CETA fast.
So
But
what
ma'am,
Dr. Rita,
ma'am, here,
yeah, tell me.
ma'am, efficacy wise, which
It's
one?
done beautifully. In fact, there have been patients in whom somewhere else or some other, earlier on I had done a 24-2 CETA standard.
Yes.
It was not a CETA fast, it was a CETA standard. And it had completely missed out on the central points. Because if you realize that the points are so far apart, that it is easy to miss out those central points early in the disease. Later on, of course, you pick them up. And then we just got a 24-2C because I do that as my first test. And we picked up a nice big central defect. And then we got a 10-2 done. And we saw that, and the patient was very uncomfortable because the central vision was affected. She was only like, I can't read what I want. She was a lawyer by profession. She had sought many opinions. And then,
So what Dr. Rita is trying to say is that CETA fast is one test, but CETA faster is what she's saying. CETA faster 24-2C, which Dr. Manish had shown in his first 3-4 slides. That's what you're saying, isn't it, Dr. Rita?
Correct.
So because it has those 10 extra points in the center, it adds to the. So CETA fast, most of us are not doing. Is that most of us are not doing? If we want a faster test, we are doing CETA faster C 24-2C. That is what we are doing.
Okay.
So
Can I add one thing?
Yeah, of course, please.
Yeah, so CETA fast application is when you're trying to detect a pattern. So mainly when you're looking for neurological or altitudinal defects to differentiate them from glaucoma. Not as a test which you will want to do a follow-up on or anything, but when you're doing it as a pattern detection. Even for, if you're looking at, you're thinking neurological or maybe an overlay of drug toxicity also, it'll quickly pick up the pattern, it goes fast, and you're not really trying to compare it to a previous test. So it helps in saving time as well as giving us the pattern that we are looking for.
So give you an overview and basically a quick screening tool, right? Maya, what are your thoughts? What do you do? When do you do?
So my thoughts actually are a little different from the panel here. I used to do a lot of CETA standard tests for all my glaucoma patients, glaucoma follow-up patients, progression analysis. But then over a period of time, with the time taken which was there, I on a pilot just tried a lot of patients on CETA fast as well, known glaucoma patients, and I saw that the tests between CETA fast and CETA standard were really not too different as far as thresholds, sensitivities, etc. were concerned. And the CETA 24-2 fast and CETA 24-2 standard both get compared on the GPA as well. So from a personal perspective, I have shifted my standard protocol purely from the fact that the test is faster without compromising much on the information which I'm getting. If there's any point of time where I feel that my information which I'm getting is not which I want, then I would maybe do a CETA standard. But so far, a lot of my testing strategy, even for glaucoma patients, whether when I'm following them up with the GPA, GPA2, I have shifted from a CETA standard, so a CETA 20 to a CETA fast 24-2. As far as 24-2C is concerned, yes, as ma'am said, maybe as the first test for somebody who has a defect, a notch which is not being picked up on the 24-2. But if there is any defect, then I would always do a 24-2 separately and a 10-2 separately if I'm going to monitor the patient forward.
So let me give a take home if everybody agrees that 24-2 standard is the standard test. Depending on your experiences, we may use the CETA fast or faster as screening tools probably.
Yes.
And if you find anything in the center,
Then you
go
go back.
ahead and do a 10-2, and that gives you much more value and information as to a 24-2C. So, Dr. Cheta, if you can ask the second question that's there in our thing.
Yeah, the second question is the importance of VFI, basically.
All right. So,
Okay.
VFI, Rupali, you want to take that? That VFI and mean deviation.
Okay,
What
so
is the
VFI,
just in short,
yeah. So Manish pointed out that the VFI is basically a center-weighted percentage-wise analysis of the field. So it gives you a percentage of where 100% is full field and 0 is loss of complete field. The only thing you have to remember here is that it uses the PSD until you get to a point where the field is lost up to 20 decibels and then it switches to MD. So suddenly you'll see that at one point it comes to like 70, 70, 65, and then suddenly it'll dip and go down and seem like it has escalated. And that is because it has shifted from PSD to MD. So you have to be a little cautious and you might want to use the actual charts rather than just relying on the VFI number.
Manish, you want to just add, you've already explained, but visual field index, how do you use it?
So
Apart
basically,
from the progression, the GPA gives you the...
when you see a chart for a quality purpose and when you want to see where the defects are, that time the VFI is of not any relevance to me. I am going to see where the defects are, whether it is central, whether it's in a nasal cluster, whether it's superior, whether it is inferior. And the VFI is an overall idea. What it gives is whether what is happening over time. So that is, as Rupali pointed out, in the early to moderate glaucomas, when you plot the graph of the VFI to see how it is progressing, that is the main use which I would put for VFI. But if you want to see just progression, VFI is not enough. As I showed in that other example, only one example I showed where the central point is progressing. So even if the VFI is almost flat, I'm not going to rely on that VFI data. I'm going to see that central point is progressing. That's going to affect the patient's quality of vision. See on the 10-2 where VFI is not calculated and treat the patient based on that. So VFI has definitely got use, but it's a limited use.
Right. So it's like, the Sensex, 20,000 gaya, 40,000 gaya, but which stock market, which dipped, it's not telling you that. So it's just give you the overall feel good factor or how bad the field is what a VFI gives. Dr. Rita, you wanted to say
Yeah,
something?
I wanted to just say that the best use of the VFI in real practice is when patients ask you, how much loss do I have?
True.
So, there is a
Very
figure
good.
to show them.
Very
That's about it.
Absolutely.
I mean, we have to look for GPA in very many other ways, like
Yes.
has been explained. But I think I've used it mostly when patients ask you, what is the amount of loss that I have?
Percentage, how much? Yes, true. Kitna
How much vision
percentage
I have.
vision loss gaya? That's right. That's
Ma'am,
an
I just have a couple of points regarding
Yeah,
the
yeah, of
VFI.
course,
So I think what ma'am has said is absolutely right. Counseling patients with the VFI, giving them a percentage, this is the drop which is there. If we are sure that has actually progressed, gives us a better idea of counseling the patients. And, in case we need to escalate treatment, de-escalate treatment, shift from medicine to surgery, all that becomes easier. The second point, I think the advantage VFI offers is the ability for it to be dynamic. By that, I mean, by changing our baseline fields. So let's say if the visual field is showing us a particular trend, and we've changed treatment, we've done surgery, or we've increased the treatment, pressures have reduced, and then we are seeing a better visual field index, changing our baselines to that point where
That's
the
important.
treatment has changed, and then plotting the graph after that to see where is our VFI going, gives us a lot of information. Like in Manish sir's example also, which he showed, if he had actually changed the baseline to a much recent one, he may have seen a VFI drop, which would be more significant if we had compared it to the last 8-9 visual fields. So the ability of the machine to of us, or, I mean, our ability to change the baselines depending on what disease the patient is at that moment may be able to give us more information which we want from the VFI as well.
So Maya has brought out a very important point that
Yes.
every time you escalate treatment or you operate for cataract or glaucoma, whatever, there will be a change in the field, and the all the remaining fields should not be compared to the first one. They should be compared from the ones where the change has been initiated, like the surgery or escalation of treatment. Um,
Sir,
Doctor, yeah. So how do I identify the blind spot? Cheta, can you take
yes.
that question? How do I identify the blind spot on perimetry?
Yes, ma'am. 15-degree temporal to the central fixation, that I know.
Yeah.
And
So
1.5-degree below the horizontal lines.
absolutely. So that's the
And
answer to
yeah, it indicates the optic nerve head.
absolutely right. Right.
There's a trick question. A lot of examiners ask PGs. They give a 10-2 and say, tell me which is the right eye or left eye based on without looking at that. So it's important for them to know that a 10-2 or a macula, you'll never know which side it is unless you look at it, because the blind spot is beyond what we are testing.
It is
That's right.
absolutely
Yes,
that's
exactly.
right. Yeah. So PGs who are going to see this, just keep that in mind. Now, how can you elaborate on the reliability of a report? So Manish has covered it very well, but now we are also talking about CETA faster. CETA faster does not do any reliability checks. So Manish, you want to, or Rupali, you want to elaborate on that? That there are no reliability checks in CETA faster.
Yeah,
Just explain it a little bit, please.
yeah. So basically, like Rita said, I don't use the CETA faster in any serious way except as a initial screening tool. And then if I find there's a central defect, I switch to 10-2 and do a 24-2 with a 10-2 rather than, even though it saves time, I still feel that 10-2 will give us a more robust way of monitoring the patient in the long term. So
No,
reliability wise, I'm not going to really look at the follow-up tests on a CETA 24-2 faster. So whether it's reliable or not really is not a big concern for me.
no, I'm talking about reliability indices.
I
Not
know.
that, means,
So indices, in the sense it doesn't have indices, you want to see how reliable the field is, right? That is what the
hmm.
indices are for. But if I'm not going to be using it to you,
Oh, got it.
is what I'm
Got it.
trying to say. Is
Yeah,
that
I got that.
That
Manish,
is never a base. That is never a baseline field. That is just a screening tool. That 24-2 Sita faster that I was telling you was, I use it on all my patients as a screening tool. I don't use
no,
it like, to compare.
I don't do serial CETA 24 as
Correct,
seeds.
correct.
so Manish, you want to see, because when a person buys a new Humphrey, it's available. The CETA faster is available only in the newer machines. So when you buy that machine, naturally you're going to do a 24-2 CETA faster. And then a person who's not a glaucoma person sees, "Arey, there is no reliability criteria checked only." So what do you have to say to those people? How do you now determine? Because we are used to false positives, false negatives, fixation losses. They're out. So then what do you say? How do you
No, so,
determine?
about the actually forget what I want to say to other people for myself. You
Yeah.
know,
So
when I see a
yourself, yeah.
field, when I see a field of a 24-2C, which has been done because you have seen something on the optic disc and you are not sure whether it is glaucoma, or you are quite sure that this is not glaucoma, but patient is very stressed and you want to show them that everything is normal. That is the time you use this 24-2C because it is fast. It gives a lot of data. And lo and surprise, if you really see a defect, then immediately you
One.
have to decide that you are going to do another test. So it is only and only got a value when it is showing nothing.
Correct.
So
The
you
moment
are
it shows something, you're going to change your whole approach.
24-2.
Yeah.
So
And
you're
in a patient where I have, when before doing the perimetry, when you just see the patient, if you have a high suspicion that this is going to have a defect, then I don't do a 24-2 C. I straight away go to the 24-2 CETA standard and a 10-2 separately. And
got it.
sometimes, and to not stress the patient, because the patient becomes your enemy if you do too much of perimetry testing. So sometimes I tell them that we will do the second part later. There's no harm. You can do it after 10 days, 15 days, second follow-up, 10-2 will be done then. Because doing too much of testing, they get fatigued, you don't get reliable data, and they get damn irritated also.
So
So
the
after 2 weeks we can do it.
Yes.
correct follow-up. Yeah. Cheta, you want to ask the next question, please?
Yes, ma'am. Actually, the next question is the calculation of percentage of the blindness or the visual disability on the perimeter print. How we can do?
Yeah. So people come for blind. None of us are in institutes which we have to give out certificates. So that's a question, that how it's a legal matter. So I don't think any of us would anyone wants to take that question, because we can discuss, deliberate, but it is a legal matter. So I would say you look at the guidelines for blindness, and that's how you give that certificate. Anybody else? Maya, you
So
want to
this,
add
this,
anything?
Having some
this,
10-2 must be having so many number of points below a certain threshold or something of that sort would be classifying it or something of that sort, ma'am. And
Correct.
only one eye, bilateral. So all those things are there. If there's visual field defect in one eye only, but the other eye is absolutely okay, then it doesn't come in the legal definition of blindness. But it has to be bilateral visual field defects which are there. But of course, this has to be looked at very carefully by the
so
people.
I think the question is not on blindness. The question is on percentage disability.
Yeah,
Percentage
yeah.
of blindness.
So
Percentage of blindness
yeah,
and
so
visual disability.
that I think the government website has somewhere. I have seen it all put up there. Now it's been a long time since
No,
I've seen
yeah,
it.
it is, that the best of the better eye should have vision less than 20 by 200, and or the perimetry on 10-2 should be less than 10 degrees. The central 10 degrees has to be affected. That is what it is. But again, the legal fine work is you have to read, and then you can give. One eye blindness
40%
is
disability.
40% disability. It is not
No,
50%.
one eye completely blind. If the other eye is completely normal field and vision is not disability.
It is 40%. No, for income tax purposes.
Huh.
It is not for as a disabled certificate, but for income tax purposes, you have to label it as 40% disability. So now, next question, can you take, Cheta, please?
Yes, ma'am. The next question is, can you elaborate how to determine the reliability of the report?
No, we have done that. We did that.
Yeah.
Fifth, please.
How to read
Now,
the perimetry report in the postgraduate examination and how to present the findings?
Maya, it's like this, that what would you give the PGs? Because they have to present in a particular manner,
Yes, ma'am.
to the examiner. So how would you ask them to present?
So I would obviously use Dr. Manish's first slide where he had divided the visual field into all those, compartment. And I think reading Understanding Automated Perimetry by Dr. Ravi Thomas' article, I think describes it in great detail. But I think obviously you start with the basic data, age of the patient, very, very important. Sometimes, again, that trick questions if the date of birth is mentioned something else and this is something else, what you need to do. So date of the birth, age should be matching. Then we go on to what testing has been done, whether it's 24-2, 10-2 seat, and if there is any particular algorithm which has been used, pupil size, what has been mentioned. And then you go to the reliability indices, depending on whether your fixation losses are less than 20%, whether whether it's reliable or not. Then you go to the raw values, then the grayscale, then come to the pattern, the mean deviation plot and the mean deviation, the values and the mean deviation plot, the pattern deviation, and finally to the indices. And then ultimately, you're depending on where the defect is, altitudinal, whether it is, nasal step, early nasal step. And of course, the main point which all postgraduates should answer, that depending on the optic nerve head status, whatever optic nerve, whether it's correspond to this visual field, and if that's the case, then you can say there's a patient of glaucoma. So identifying glaucoma only on the basis of visual field is incorrect, because the definition of glaucoma says that it is optic nerve head changes with corresponding visual field effects. So if the optic nerve is something else and the visual fields are something else, then that's not a correct, that's an incorrect, that may not be glaucoma at all. So whenever they are answering, I think asking what is the optic nerve head like before reaching your final diagnosis tells the examiner then and there only that he knows the definition, he or she knows what she's talking about, and that makes the answering easier. But stepwise approach is the way to go forward, answering in all these ways.
So beautifully said, Maya. I'm going to the last question first because the others are all clinical questions. None of us have any financial interest in any of the machines mentioned, but this thing is how good are or what is the best perimeter for an average OPD? Average OPD, I think that person means, our colleague means comprehensive ophthalmologist. So it's an important question. I think all of us are asked that question. So Manish, let's go with you first. Which one would you advise to buy?
So I think that I would not advise a particular machine, but generally I would say that you have to decide on your budget, and even a general ophthalmic practice can have a big budget. Then definitely I would recommend to go for one of the machines which are backed up with strong population based and glaucoma based statistics. There are only two machines which fit that bill. That is the Humphrey and the Octopus.
Right.
All the other machines are in a different category. Amongst those other machines, so first you compare the prices. If it is like half the price or something, then you have got, and even these machines are coming in economy versions. The Humphrey and all do have entry-level machines.
The entry-level machines are much higher than
Yeah, they will be higher. They will
double
be
the
higher.
price. Yeah. So
it will be double the price.
correct.
Now, I will say that if you are using for only screening, then any of the other machines, including Appa, Optopol, they are also good. And in fact, I will go to say that even those newer those
Virtual
devices which have
reality.
come, yeah, the
Perimeter.
virtual perimeters are also good for that purpose. For the purpose we are talking about is not seeing glaucoma patients and evaluating progression, but screening patients for visual field defects. Then some of these, the scanners or the virtual perimeters are also good, as are all these other machines. So for an entry-level practice, but once you have a patient and then you have a glaucoma patient, and then you should have the insight that your machine has got a limitation. So refer the patient for perimetry to a center which has the perimetries which are applicable for glaucoma follow-ups.
Rita, which one
Yeah,
would you
I agree
recommend?
completely with
You complete.
absolutely.
Maya, what about you?
I would agree with sir completely. Whatever he said, I think is absolutely sacrosanct. But if you're having practice where you're doing serious glaucoma work, then having a serious and good perimeter is important. And if you're doing good glaucoma work, you have to do perimetries to make sure that whatever you're doing is backed up with data. So just doing glaucoma surgery is a lot of medical management, but not doing perimetries is not the correct way forward. So if you have high volume glaucoma work, even if you are a general ophthalmologist, a comprehensive ophthalmologist, a perimetry machine, I think, becomes very, very important for you. And between these two, both are equally great. I personally, the Octopus is very complicated with a lot of indices. But whatever works and whatever somebody has been trained in is very, very important. Again, that is again, in your training institute, where what you've been trained in and what you're comfortable with, go ahead with that.
So basically, if you have these can be, the other perimeters can be screening tools, but if you have a glaucoma patient, the person has to be put on either Humphrey or an Octopus. So that's, if there is any difference of opinion, let me know. Otherwise, we'll go to the next question. Cheta, can you take the question number 6, please? You're muted. Cheta, you're muted.
Yes, ma'am. But already, sir has explained it in a very well way. The early signs
7.
of the glaucoma, nasal steps, and all these things.
Okay.
So,
7.
ma'am, seventh is not yet. Ocular hypertension, ma'am.
Yeah.
What is the approach for the ocular hypertension?
So this is not perimetry related. This is very
But
clinical related, but we should
yes,
take it.
ma'am. But
Yeah, it's asked and we should answer. So, okay, Rupali,
Yeah.
what will you do for ocular hypertension?
As in visual field wise?
No, it's a treatment. That's all. What is the approach for ocular hypertension? I think it's a treatment. So, just in short, if you can.
So, ocular hypertension first is define the ocular hypertension. So, anything above 20 on at least 20, I would say 22 on at least 2 or 3 occasions consistently, where I would look at the corneal thickness, look at the risk factors, and if their disc is healthy, I would just follow them up. The follow up would be dependent on the risk factors. If it's a higher risk, I would follow them up possibly 4 to 6 monthly, and I would probably do an OCT initially rather than a field because it might not show up. And if the OCT starts to show changes, then I might consider putting them on treatment. Unless the pressures go up to like 28, 30, where the risk of a vascular occlusion or something is there. Until and unless that is there, I would be reluctant to, like for 24, 26, I would not treat them. If they are low risk and have absolutely normal disc and OCT.
So, ma'am, here
Sorry,
the target IOP should be properly fixed in this case.
Yeah, but if you want to treat only, then you'll have a target IOP, right? I am kind of saying not treat only.
Okay, ma'am.
She's saying that treat low IOP shall not treat. So, Manish, what is your threshold for treatment in a healthy corneal thickness with a normal corneal thickness?
Basically, I also go by the same thing. Anything which is about 27, 20, I would treat because the risk is higher for vascular occlusions. I would like to just bring out one point which is very relevant since we are talking of ocular hypertension, is the very, very widespread trend of correcting intraocular pressure to corneal thickness. And in fact, you have machines which do it for you.
Yes.
And it is everyone is doing it all the time. When they even I see the handwritten notes, corrected IOP this much. So that is one thing that I would strongly like to send a message, is that that is something you should never do. Higher risk, yes, thinner corneas are a little higher risk. You adjust a lower target pressure, but don't every time you take the pressure, don't keep on correcting it for corneal thickness.
There is no correction formula, is what Dr. Manish is trying to say. And whatever your electronic health record is correcting, is God knows what it is correcting and what formula it is using. But there is no formula which has been like adopted or recommended. So now the one of the questions is,
There's
if
one point.
yeah,
Preeti,
sure,
can I
sure,
make
sure.
one point? The
Of
only
course.
one point I would like to, add on to this ocular hypertension thing is that there are some people who are extremely, sort of numbed by figures. So there are some people who are extremely particular. So they have had, lots of references. They've done a lot of Googling. So they come out and ask you this question. So if their pressures are between 24 and 28, I normally discuss things with them. I don't start them on treatment because they don't need the treatment. But it is a good idea to take them into confidence and discuss this point with them. If they still insist that no, we will be more comfortable with treatment, then maybe I will start one single drug. But I normally dissuade them from taking treatment. But 28 and above, yes, we will definitely start.
Okay.
And ma'am, one just last point.
Yes, please.
Just all pressures on applanation tonometry only.
Correct.
True. Not
Yes.
yes, that's
Not
an important.
NCT.
True, not NCT.
There are so many people who have come treatment on
Glaucoma
NCT.
are treated on NCT, absolutely. So this is what it is. Approach. Can I just have a thumbs up for whether you would say SLT for ocular hypertension? Those who would start. We are those who would start. Okay, so Dr. Manish, Dr. Rita, Dr. Rupali. What about you, Maya? No thumbs up from you?
I don't do SLTs, ma'am.
All right, fine. So thumbs up from me also. So 4 of us would do SLT. What about you, Cheta?
Yes, ma'am, of course.
SLT 5. You're outnumbered, Maya. So now the last question. If damage is seen on perimetry done by the patient for the first time and is seen to be reliable, the IOP is borderline suspicious nerve with positive family history of glaucoma. Should we wait for repeat perimetry, or should we start AGM, repeat perimetry after 2 months and then decide whether to continue treatment or stop? I don't know if you understood what I said. So You
No,
understood
it's a
what
very,
that-
very, very, very clear question. Whoever has
Yes,
put this question has put it very clearly.
very clear.
And so I
huh.
will just make it a little more clear for the person is that when you say visual field damage is seen, it is very critical to see where the damage is seen. So if it is some small patch in the nasal step region, just 2 points, or in the superior field at the edge, 1 or 2 points, then I would happily ask the patient to come back again for a perimetry. But anything which is close to fixation, I don't want to wait for reconfirming these defects, especially since it is backed up with structural correlation. I would definitely like to initiate treatment immediately.
So if you're confident that it is a glaucomatous correlating with your disc, then you would not want for a repeat one. To confirm your diagnosis, you will start treatment.
I would
Yeah.
like to disagree with Manish on this.
All right, go ahead, please.
Sorry. But you know what? However much you want to say, I think we also have to admit that we always look for a reproducible perimetry. And it is quite possible that if we don't start treatment on that first visit, we can always call the patient back in 15 days and see whether that defect is reproducible or not. Because glaucoma is not a cancer, it's not going to progress in those 15 days to that extent. And once you start treatment on that patient stays on treatment forever. Whether you like it or not, it is a very difficult question to decide after somebody has started treatment, should I discontinue this treatment or not? That's why I think it is very, very, very important for us to give some time, call the patient back maybe in another 15 days, repeat the perimetry. And if you're getting the same reproducible defect, then there is absolutely no doubt that then you can now start
So
reconsidering.
now, Rita, counter question to you.
Yes.
The same patient
Yes.
has got structural change, has got a notch, has got a nerve fiber layer defect, which is corroborated on OCT, but has no visual field defect.
Correct. That is also possible. I mean, we see that in green, in jet
All the
diseases
time.
and
Yeah,
stuff.
it's quite
Yeah.
common. In fact, it is not a rare finding at all. Only thing is that in this patient, you would definitely do a 10-2.
Yes, of course.
True.
Even that 24-2C is not good enough.
Yes.
I
Yes.
agree with you completely.
Yes. Okay.
So,
So at least we
thing is,
finally agree.
yeah.
Mostly
So what you have to realize, the viewers, that these are areas which are gray zones. You're not always right, you're not always wrong. But the important thing is counseling, and having a follow. So whatever you decide, and what Dr. Rita also says, that once you start treatment, it goes on to records that okay, treatment was started, and forever he or she or they are labeled as glaucoma patients. So both are depending upon how strong the correlation between structure and function is. You are justified in starting treatment. However, if it's not very strong, you can also call the patient back, but counsel them that you have to come back, not come back after a year, 2 years, and land up and have an advanced field effect. So it's 9:30 now almost, and
spend
it
more than
was,
enough time.
yeah. So it was a wonderful session, Dr. Manish. Thank you so much for this, for that extensive talk. It's not easy to compile it in 40 minutes. Dr. Rita, Dr. Maya, Dr. Rupali, thank you very much for your insights. Cheta, for being a wonderful co-moderator.
It's my pleasure to speak with all these stalwarts.
They are, so many are from Mumbai, like I'm
Yeah,
proud
I
of
know.
it. That's how. So, and of course, Numerotech for giving us this platform. And oh, Anaga is here. So, and
Hi,
of course,
yeah,
Anaga
very
from the
nice.
lecture learning.
Wonderful presentation and wonderful discussion too.
So I
Really
was just
nice.
saying thank you to all of them, and of course to
Yeah,
Numerotech.
thank you so much.
And good night, everyone.
Good
And now
night.
there will be
Thank you
retain and
very much
revise
Thank
series
you,
tomorrow.
everyone.
for
Okay, bye-bye.
curating
Good
this
night.
program
Thank
so
you.
nicely. And I'm sure all the audience is going to thank you because you are really an expert at this. Thank you very much.
Thank you.
Thank you,
madam.
Preeti.
You are amazing.
Bye. Good
Thank
night.
Thank
you,
you,
everybody,
everyone.
and good night.
Good
Good
night.
night.
Thank you. Good night.
And more such sessions.